Real life, ma'am.
Thanks a lot. Good evening, everyone. I take this pleasure to welcome you all to this amazing webinar series that we have been doing. I present to you the innovations in pediatric hematology oncology, and this is a special webinar series we are conducting targeting the much needed discussions on brain tumor. So today we have a very important topic for discussion, which is new updates and a practical guide for the management of pediatric high-grade gliomas. First, before starting, I would really like to thank you all because you have been really flooding our DMs post these webinars with questions, and we are really open to taking them for the discussions. And I really thank all our international faculty for being so prompt in answering all the queries over mail as well. Are my slides moving? Yeah. So I take this pleasure and intense pride in inviting none other than Dr. Anirban Das. He's a MBBS, MD, and DM, and is currently Assistant Professor, Department of Pediatrics, Neuro-Oncology Section at Sick Kids Canada. Dr. Anirban has been doing amazing work in pediatric neuro-oncology and has recently become a to-go person for all the discussions. I welcome Dr. Anirban to this platform of your own people and your own discussants. Here you go, and the platform is all yours. We'll take Dr. Anirban's lecture first, and you can ping me all the questions. We are open to discussions, and all the questions will be taken at the end. You can share your screen, Dr. Anirban.
Yeah, thank you, Dr. Swati, for the kind invitation. It's a pleasure to be here and present some of our data and the work that we have been doing. Can you hear me? And
Yes,
can you see
audible,
my...
audible and visible. Yes.
Okay. So let me know which screen you are seeing. Are you seeing the presenter mode or the full screen?
No, we are seeing the presentation mode.
So let me switch.
Yes,
Can you
it
see
is
the
full
full
screen
screen
now.
now?
Yes.
Okay. So can I start now?
Yes, sure, sir. All yours.
So again, thanks for the kind invitation. My name is Anirban. I am one of the pediatric neuro-oncologists at Sick Kids and University of Toronto. And today, Dr. Swati has kindly invited me to talk about some of the recent updates that we are facing in pediatric high-grade gliomas or PHGG and how we can be using some of those resources to guide our own patients back home in India, because we are all aware that there are some fancy molecular diagnosis, fancy treatments that are upcoming. But of course, they are all not effective as far as we would want them to be in some cases. And there are logistic barriers for global dissemination of some of those practical points. So I will try to highlight what's coming up and what's happening, but also try to be grounded in saying that these are the practical things we should do for our patients today in India, wherever we practice, and be aware of the things that are advancing and going ahead in the field. So with that, I will start with the background basically. So pediatric high-grade glioma is 15% of all CNS tumors in children and adolescents. And things unfortunately have not changed, unlike in medulloblastoma over the last 50 to 60 years. This is the data from the last COG trial, ACNS 0423, where they used biopsy/surgery followed by focal radiation, followed by temozolomide and CCNU, and the radiation was with temozolomide. And you can see that on this backbone, the outcomes were what you can see in this curve over here. And though the CCNU after addition to temozolomide did make a difference in comparison to the historical trial ACNS 0126, which had temozolomide alone, it was nothing very remarkable to write home about. So this became the standard of care for high-grade gliomas before the molecular era. And when we had a molecular era, things are trying to be sort of being changed over time, but the backbone still remains that we try to do surgery/biopsy, do focal radiation with temozolomide, and then continue temozolomide and CCNU as maintenance for most of the unclassified or the global management of pediatric high-grade glioma. Because the outcomes were so dismal, so of course there was effort, as in all of pediatric neuro-oncology and adult neuro-oncology, to understand these tumors in more detail and try to find out how we could improve the outcomes. And that's where the molecular classification that is part of the current WHO classification has come up. And it's not straightforward, but there are some practical aspects that we need to be aware of because we have to provide a diagnosis to our patients, and then comes the management part. So as you can see, in pediatrics, high-grade gliomas are very different from adult-type high-grade gliomas, and majority of them have mutation in one of the histone genes. You can see over here, histone 3.3 K27M, 3.1 K27M, and the hemispheric tumors, which 3.3 G34R. This forms almost half of the tumors in childhood pediatric high-grade glioma, but there are other certain types that you can see over here. Some of the adult type IDH gliomas that we are seeing more and more in adolescents and young adults as the children become older, because though it's an adult disease, it actually has its origins in childhood, and there are other molecular drivers that have been identified. So we will focus on some of these molecular types of high-grade gliomas and see how they may impact our practical management on a day-to-day basis. And I will start with the most common type, which is the histone K27M mutant high-grade gliomas, which you can see from the majority of the childhood high-grade glioma spectrum and have the probably the worst outcomes that we unfortunately see within the whole spectrum of pediatric brain tumors. So as many of you know, the current terminology is diffuse midline glioma, and this includes not only the radiological diagnosis of what we are all always sad to see. This is DIPG, or diffuse intrinsic pontine glioma, which fools almost the whole of the pons and is a devastating disease. But it's driven by histone mutation, and now we know that even if there are tumors in the other locations on the midline, for example, in the thalamus or in the brainstem or even in the spinal cord, if they have the histone mutation, they're equally bad. So that's why the broader terminology is DMG, or diffuse midline glioma, because though majority are still DIPG, there are other entities elsewhere which are molecularly characterized with the same mutation and have the same dismal outcome. So these, when they are in the pons, are usually unresectable for obvious reasons. And this is a subset where more and more there is data to suggest that chemotherapy really doesn't work. And there is still debate, but it's also important for our patients to know what is not effective or what is not useful, so that we maintain their quality of life and don't add up side effects for a drug which is not effective. So diffuse midline glioma, if they have the K27 mutation, probably temozolomide is not effective. So we are not wanting to add a burden of chemotherapy to a child where the outcomes are otherwise dismal, and chemotherapy that will probably add up to only side effects without any improvement. Radiation is very effective for control, but the median survival, as you can see, is very poor within a year, and almost like nobody survives, and it's the most common cause of cancer-related death in young children. Depending on the type of the mutation, the survival does vary a little bit. If there are hemispheric tumors with histone G34RV, which are not DMGs, they have slightly better outcome, as you can see over here. But the histone 3.3 and the 3.1 K27s, which form or characterize the DMGs, are uniformly dismal in outcome. So the important message is to say that, okay, you have the mutation, the location can be anywhere, your outcome is going to be unfortunately poor today. Radiation is effective, and maybe you don't want to use chemotherapy because it doesn't really work and adds up to financial as well as toxicity burden. However, re-radiation is an effective modality for disease control in these patients. So you can see work pioneered by Derek Sang from Sick Kids, who has treated many of these patients. And once you treat them at diagnosis, you can treat them again with radiation for a second time, because all of them do progress after the first radiation almost uniformly. And the data suggests that if you treat them with the radiation a second time, you can prolong their survival by up to 4 or 5 months and reverse some of the debilitating symptoms that come up at the time of progression. So radiation or re-radiation is not only effective for prolonging the survival, it's not curative by any means, but also leads to prolonged survival and good quality of life that we have seen in our patients. These numbers are also important to take into context, in the context that there are many new treatments coming in, as you probably are aware, and some of these are based on second dose of radiation versus sometimes even a third dose, which I will talk about in the next slide. And as you can see, repeat radiation courses can extend the survival, which is from 1 year to up to 2 years. So this is sort of the baseline that we should benchmark to understand how the future newer drugs are actually working better or not. So it's a good benchmark for us to know that radiation and repeat radiation can sometimes increase the survival to up to nearly 20 to 23 months. And not everyone behaves that well, but there is a possibility that some of these, and we don't understand who and when, may behave differently and may have better outcomes as compared to in terms of survival at least. So this is our recent publication from this year, which suggested that radiation does work. You can see the survival difference for the patients, but ultimately, unfortunately, they all die. And patients who have good response to the first round of radiation seem to be having a more benefit of a second round of radiation, which is shown over here. And in very rare cases, we have even done third or fourth courses of radiation. This is a small case series, again published recently, that suggests that if you're careful and if your radiation oncology has enough expertise and confidence, radiation can be given to prolong survival as well as maintain some quality of life. And Derek Sang is, as I mentioned, one of the world's experts in radiation of this difficult disease. So now coming on to what we can do beyond radiation, because we already know that surgery is not really feasible and chemotherapy doesn't really work. So what else can we offer to our patients sitting today into April 2025? So as you can see, this is from clinicaltrials.gov, and unfortunately for DMG, most of the clinical trials, there are so many of them active and recruiting, but most are phase one, which basically means in a bad way that nothing has progressed beyond phase one in a real way to have real efficacious and real benefit for our patients. So when we are practicing in resource constrained settings, sometimes we get frustrated by seeing some good results that are published in good journals, which I will come to, and sometimes we hear in conferences. But unfortunately, for this particular disease, the bottom line is that nothing really is curative. So we do what we can for our patients and don't get frustrated that we can't access drug A or drug B. Still, because we want to know about the updates, I want to classify these clinical trials into three kind of approaches. One which includes inhibitors and small molecules, one which is trying to sort of use the immune microenvironment and target that, and some of the other technological advances that are improving drug delivery, because the PONS is a very compact site and not all the drugs that we want to give have their effect because they can't even go into the brain and go into the tumor. And I can't talk about all trials, but there are three sort of approaches or three sort of drugs that I want to talk to you about today. And I will start with ONC201, which some of you may have heard who have worked in the DIPG field, because there has been a lot of hype. But again, as clinicians, we have to be aware of what is hype and what is true when we are asked questions by our patients. And of course, before we actually give them a treatment that may or may not work. So ONC201 is actually not a new drug. It's an old drug which has been sort of repurposed. It's not a cytotoxic agent. It is a dopamine receptor D2 antagonist, which actually we are still learning how it works. But the hypothesis is that it causes a form of apoptotic cell death that sort of leads to an immune microenvironment effect and may have benefits in many tumors. And it has been tried not as a specific treatment for DIPG, but in many sort of tumors. And this is one case where it was sort of touted to be very promising. But we will have a look at the data ourselves to see if that is really true. So this is a paper that was published, and you can see that the survival curves look better than what we saw on the initial COG clinical trial survival curve, where everyone dropped down to zero. But if you look carefully, you can see that many of these patients were not recurrent. So they are not starting from traditional trial standpoint where you start a new drug at recurrence and then measure survival. They took the survival from the diagnosis, and many of these patients may have got re-radiation. So if you remember, the re-radiation effect actually pulled some of these patients to 21 months. And with ONC201, it seems that it's almost the same. So that data was not very clear from the trial. And as you can see, this is not in JC or NEJM, but in cancer discovery, where there was a lot of biological correlates that was sort of shown that the drug is doing something, but it's still ambiguous and it's still open to debate whether it really helped patients as it was touted to be. So the caveats of this data are that there were many patients who had initially non-progressive disease, and many of the patients were actually older and had thalamic disease. And we already know historically that within the diffuse midline gliomas with K27, The ones which are not pontine, which are like outside the ponds, may actually have a better survival. They all are lethal, but they may have a prolonged sort of survival effect. And we already knew that older patients sort of kind of did better and survived longer. And it was not very clear whether some of these patients also got radiation because they started like on a drug after their diagnosis, soon after the first radiation, and could get any other treatment in parallel. So it was not a very strictly designed trial, and that's why the data has been criticized, and there are believers and non-believers in the neuro-oncology community. The people who published, of course, say that this is a good data, but there are several rebuttals, including in JCO, saying that the data has its caveats. So it's not a drug that we, if patients ask, we should be saying that it's a magic drug that works wonders, but there is something happening in the tumor and the microenvironment, and maybe there are some patients who are benefiting. So the proper trial is actually happening now, which is a randomized trial because the previous one was not even randomized. And this is looking at the subset of patients who actually did better. So the thalamic gliomas and the older patients are being studied specifically in this trial as a randomized arm to see that whether this drug actually causes any benefit or whether it's something which is not very effective, because there is no mechanistic reason why this drug should be really a magic drug in DIPG. So moving on from the hype about ONC201 to the reality about the CAR-T trials. And as you know, in India, we have CAR-T trials for leukemia now, where all of this started. And people started to use or try to use CAR-T in DIPGs and DMGs as well. And it's not like leukemia that you have a single driver process or a single antigen that is expressed widely that can be targeted. So many people sort of sought out antigens which were highly expressed in majority of patients and tried to target them. And this is the group from Stanford who chose anti-GD2 and developed an anti-GD2 CAR because GD2 was highly expressed in around 60% of diffuse midline gliomas. And they developed the CAR-T as a clinical trial to give both intravenous and intraventricular, and then do a combination of both. And you saw it's a Nature paper with 4 patient case series that suggested that some of these do respond, and you can see the benefit in the patient. But again, there are caveats, as you can see, an older patient, and it was not that somebody was cured and is alive forever, but it did push back the survival to 26 months and even 30 months, as we will see. And again, the spinal patients, the non-pontine patients seem to have like better outcomes in a way. So it's promising to see that the immunotherapy approach of CAR T cells targeting GD2 have some good effect. And this is published again in Nature last year that shows that there are some patients who have radiological response, as you can see from here, and some patients surviving for over 30 months. But these are outliers, is what the consensus of the community is. And we don't really understand why some patients did better, but maybe there is a signal that there is some biomarker or something that can make some patients respond to this sort of treatment. So as I said, it's not like a specific driver process is actually active. So people are targeting different antigens. This is a group targeting B7H3 instead of GD2. And the results are more or less similar, that there are some outliers who are having prolonged survival. But again, not everybody is responding, and the responses don't seem to be durable. There are many mechanisms of why CAR-T doesn't really work in a generic way. And as you know, one of them is antigen escape. So this is a group that is trying to target multiple antigens at the same time. And there are other mechanisms where it suggests that the CAR-T cells really go in and then the macrophages don't allow them to work. And maybe they are not even able to go into the center of the tumor. So the CAR-T summary for DIPG is that people are targeting different antigens, even multiple antigens, and it is causing benefit in some patients by prolonging their survival, but the effects are not durable beyond maybe 36 to 40 months, which is a big jump from 12 to 24 months. It's almost double, but not like curing these patients. So that is the reality that we are dealing with right now. And of course, the technology is advancing, the trials are ongoing. So we'll see what happens in the future. Other immunotherapy approaches, you can see DIPG treated with oncolytic virus with intratumoral delivery of the virus that elicits an immune response. Again, an NEGM paper because there are some patients who did better, but again, the responses are not durable, and it's not something that we can really offer to our patients anywhere in the world because it's neurosurgically challenging procedure. The drug or the compound, or rather the virus, is not easily available to everyone. So it's something that suggests that triggering the immune system by using different mechanisms may benefit some patients, but we are yet to learn because, in a generic sense, DIPG is an immune cold tumor. So there are endeavors to make it sort of immune hot and see that if immunotherapy can benefit some of these patients. This is a trial that we are doing in sick kids right now. And I talked about the blood-brain barrier and how that actually makes drug delivery difficult. And here it's a technology where people are using focused ultrasound to open the blood-brain barrier and allow drugs and molecules to go in. So it's a novel concept of delivering some of the drugs that are probably effective in cell lines, so in vitro, but don't really go into the brain. And again, early days, we have a clinical trial with human patients being enrolled. So we'll see if that is successful or not. So we work with Nada Jabado, who is the person who discovered the K27M mutation, and Cynthia Hawkins and Peter Dirks and Sikkis. We are fortunate to have these stalwarts who discover stuff. And we have many of the exciting clinical trials involving inhibition of anti-CSF1R or the macrophages with checkpoints. So this is all ongoing work. But again, the summary, I think, is to say that there is excitement in the field, but the reality is that for DMG or DIPG, radiation and re-radiation are the standard of care still, unfortunately. Chemotherapy is probably not effective. Biopsies becoming routine because that allows us to enroll patients for clinical trials, and there are some encouraging data for different trials. But the bottom line is that it remains an incurable disease where we need probably combination strategies in the future to make sure that we actually benefit our patients. So moving from some of the frustrating aspects of DMGs or histone mutant gliomas to some other types of high-grade gliomas where the promise and the impact are real today. And V600E is very common in low-grade gliomas but can happen in high-grade gliomas. And here there's a clinical trial published last year led by Eric Buffet from SickKids that clearly showed that if you have a high-grade glioma with V600E, you can treat these patients with a combination of dabrafenib and trametinib. You can see the response rates here, complete response of disease in many, and a real impact on survival that may or may not be sustained, that we have to still wait for the longer follow-up. But it seems that if you have a V600 mutant high-grade glioma in children, you can effectively treat them with targeted treatment and have good outcomes for these patients, which were initially, as you saw here, we're doing like better on the backbone of targeted therapy. So that's the new hope. And as you know, V600E is like a simple IHC. So it can be done by anybody, anywhere in the world. And the drugs, I know it may be a challenge to access that. But again, we can ask. When I was practicing back in India in 2016, we did get access to one of our patients. So it's like trying to work with pharma and trying to work with companies so that they are invested in developing generic products. So maybe not for today, but it's good to know that this is a subset that is showing response to targeted therapy, even if they're high-grade tumors. Now, moving on to the other types, which is like a whole basket of tumors with different molecular drivers, but I want to highlight some of those which are clinically relevant and maybe important for our daily practice. So this is a patient who presented at 11 years of age at SickKids with a spinal high-grade glioma, which was already a bit odd because though it was high-grade and had like gone through multiple rounds of chemotherapy and radiation, it was still progressing, but the patient was alive. So we repeated the biopsy at sick kids and found NTRK fusion, and we had a drug or a clinical trial open against it. So we treated the patient with the drug, and you can see that the high-grade glioma has actually disappeared. So this is NTRK fused high-grade glioma, which is actually a type of glioma that is usually seen in young children. So it's called infant type high-grade glioma. And as you saw, our patient was 11 years of age, but was diagnosed when he was pretty young. And this is a biological process where young children and infant in brain tumor world doesn't mean less than 1 year of age. It means at least 3 or even up to 5 years of age, where patients present with these large, ugly looking, morphologically high-grade tumors, but have alterations which are seen in lung cancers where we have drugs, and with the use of targeted therapy, as you can see in this previous patient, the tumor disappearing, and other reports published by our colleagues in St. Jude's, you can see the bad nature of the tumor itself on the radiology, but then complete remission with targeted therapy. So testing for some of these alterations is important because these infant type high grade gliomas are really not high grade gliomas because they don't like kill immediately like the K27Ms, but sort of linger on. But they are very devastating unless you really find the alteration and use targeted therapy against that. And this has also sort of become a standard of care, at least in the West, for these kinds of tumors. Drug access may be a problem in India, but again, we work with our pharma partners and try to find out how we can make the drugs available to our patients because these are like rare patients. These are not like common, and there is some incentive to do good from many of the pharma companies where we can like request and get the drugs. The testing is something that I think we have to work with our pathologists because many of the testing is already available for adult lung cancers. It's only our responsibility as pediatric oncologists to tell our pathology colleagues to use some of those tools, including ALK-IHC or other sequencing platforms to diagnose that they have those alterations, because you can see the effect that the drug has once we identify the alteration and treat the patients appropriately. So moving from the story of infant high-grade gliomas and V600E high-grade gliomas, where we have seen the magic of targeted therapy, to another form of high-grade gliomas where there is a lot of cancer germline predisposition and cancer genetics involved. And those of you who know me know that this is one of the cancers that I am personally passionate about. And it all started of how genetics in a genetic sense is linked to cancer genetics. And as you can see here, these are like looking the same, not the same. It's actually a human sitting over here and not plastic bags. So it's learning that sometimes what we see in a genetic way may be something unique and trying to appreciate and learn from that. So in SickKids, we work with different countries because we don't work in isolation. So we have regular rounds with the Middle East led by people from Jordan and now from China, Brazil, and even Pakistan. And this is where it's a two-way learning process because we learn from our colleagues and see new things and see and learn new things that we could never see working in isolation in SickKids. And this is one of the stories that I want to share with you. This came to Eric Buffet and Uri Tabori, who are my mentors, as a 5-year boy with NF1, which is a kinetic cancer predisposition syndrome, which leads to low-grade gliomas, as many of you know. But this was a boy presenting at 5 years with a malignant brain tumor. There was consanguinity and there were Caffiole spots, but there was also family history of cancers, and there was presentation with a malignant brain tumor. And on the MRI, there was not only a single tumor, but actually two tumors in two different locations, which are sometimes, as you know, called as metastatic. But under the morphological examination by Cynthia Hawkins, who is one of the world's renowned neuropathologists and works in sick kids, they looked very different. So one was a medulloblastoma and one was a glioblastoma in a so-called patient with NF1. And of course, we now know that this is not NF1, but something known as constitutional mismatch repair deficiency, where these four MMR genes, which are very important for maintaining DNA fidelity, and one of them may be lost in the tumor and in the germline of the patient. So there is no expression of PMS2 in this tumor, which otherwise should look like brown dots when the tumor protein or the protein is actually expressed. And this can lead to a cancer predisposition syndrome that we are becoming aware more and more, that can lead to devastating brain tumors, most commonly pediatric high-grade gliomas. So in a very simplistic term, when the cell divides, the DNA replicates, and there are errors that can happen during this replication process. And these are prevented by the mismatch repair system and the polymerase proofreading system. And when either of them are lost, this leads to cancers with high rate of genomic instability in terms of mutations, as well as insertions and deletions, which are more common in the microsatellites. So we started with CMMRD, where there is germline biallelic deficiency in either of these four genes. But we now more and more know that there are other patients with either Lynch syndrome, which is the heterozygous state, and other mutations, as well as some sporadic cases which have the same biology. So we think it's broader than being a rare syndrome. It's actually a pan-cancer mechanism. So because of the hypermutation, these tumors were very aggressive. So everyone sort of died on chemoradiation. And temozolomide is a drug that doesn't really work in these patients. Again, like diffuse midline gliomas, the reason here is different because temozolomide needs an intact mismatch repair system. So of course, with chemoradiation, everyone recurred, and after recurrence, everyone died in 2 months or 3 months. And after using the fact that they had hypermutation, which was clonal because it was an early germline event, we started using anti-PD-1 immune checkpoint inhibitors and saw remarkable responses. This is actually my patient from Tata Medical Center in Kolkata when I was practicing there. And you can see glioblastoma, recurrent glioblastoma disappearing, and a survival from here going to here, and patients who were dying in 3 months surviving for more than 4 years over here. So we did a clinical trial in Europe and North America, but we also in parallel use this data to allow our pharma partners to give access to many of these expensive drugs in low and middle income settings. So there are 45 patients, and these are not patients from North America and Europe, but from elsewhere where the trial didn't happen, but worked in parallel with the registry mechanism to treat patients uniformly and get much more robust data in terms of numbers than we actually got in the clinical trial. Because these patients have germline predisposition to cancers, they can develop other cancers. So you can see colon cancer, big tumor here, metastatic to the bone, and a glioblastoma. But because they arise from the same biological mechanism using anti-PD-1, all of them responded because all of them were hypermutation and carried microsatellite instability, and that's why they were sensitive to anti-PD-1 inhibition. So what we thought was a rare syndrome in children, now we know, and this is published this year in Lancet Oncology, and this is one of the students in the lab who led this, that this mechanism may actually be much more common in Lynch syndrome. And Lynch syndrome, as we know, is not an uncommon phenomena in adults, but Lynch syndrome is usually colon cancers and endometrial cancers in adults. And usually when children and young adults develop glioblastoma, nobody even thinks of Lynch syndrome or mismatch repair deficiency. But this data suggests that there are like 5 to 12% of these patients that can present with this biological mechanism. And the impact is quite clear that if you have MMR deficiency or replication repair deficiency, it doesn't matter if you are a child or an adult, doesn't matter if you have CMMRD or Lynch, you have a good response with immune checkpoint inhibitors, provided you diagnose them properly using proper tests. So this is something which is an evolving era, and now we know more, and I don't want to spend too much time on this, but I can talk for hours because this is what I work on. So we know that there are some patients who don't respond or sustain respond to anti-PD-1, so we can target other immune checkpoints here, anti-CTLA-4, and there are other newer checkpoints coming like anti-LAG3, and this is a patient who failed previous treatments but then responded to anti-PD-1 and LAG3. And now we are like, this patient was diagnosed in 2018, and now we're in 2025. The patient is in complete remission, and we are thinking of like stopping treatment right now. So we are entering a new era for a subset of tumors which have this biological mechanism. Again, you can see diffuse spinal involvement with high-grade glioma, post immunotherapy and radiation treatment, complete remission, patient surviving for more than 2 years. So we work, as I said, not in isolation, but with colleagues from across the globe. So mismatch repair deficient high-grade glioma is still not a part of the WHO classification system. That's why we get this question every time, that who should we test? Why should we test? So we are making a concerted effort given the impact of bringing this into the classification. So this is a European standard published earlier last year or like later last year, where this is already a group. And right now we are working with the C impact, which is the precursor of the next WHO classification, to make sure that this entity has its own diagnostic criteria because of the big impact that immunotherapy has had for these kinds of tumors. So we or there is now awareness globally that immune checkpoint inhibitor works, but we are learning more and more as we probe deeper. And we now know that all these are not same, because some of these may have additional driver mutations that make them more responsive to immunotherapy, whereas some of them have certain driver mutations that don't make them amenable to immunotherapy. So there are different subgroups and different trials, and these subgroups will be like published because they are now under review in Nature and will become part of the future WHO classification in the next iteration. So it's not only as simple as saying that we have a RRD or MMRD hybrid glioma, but it's important to classify them, because right now we have a clinical trial for a very good outcome subgroup where we treat with resection and immunotherapy alone. So no radiation, no chemotherapy. And we have excellent survival. We have a clinical trial open in sick kids, already accruing to patients. And as I said, we work with partners. So this clinical trial will open in Tata Mumbai soon as well as in Jordan, along with the Western countries that we usually do trials with. Similarly, for the patients which have IDH mutation on the backdrop of mismatch repair, we are using a combination. And again, this is a clinical trial that we think we will have a partner in Tata Mumbai in India, and maybe the patients in India can also benefit from some of these discoveries that we are making over here. So talking about IDH, this is the last group of tumors that I will talk about today. As I mentioned, IDH gliomas are usually not thought to be pediatric gliomas because these are like adult gliomas, which are usually low grade and then transform and become high grade. They have a lifespan of like 10, 20, 30 years. In the end, everybody dies because they all transform, have P53 and other bad hits, and become high grade. But it's not like a pediatric high grade glioma where death is imminent in front of your eyes. But what we as pediatric oncologists are now appreciating more and more, that though this is an adult disease process, it has its origins in childhood. So you can see my colleague Julie Bennett here, who is an AYA neuro-oncologist. So she works both in sick kids and in Princess Margaret, which is the adult hospital. And she showed that IDH mutant gliomas can actually be diagnosed in older children, like children who are 11, 12, 13, 15, 18, young adults who are 24 and 30 years of age. And those who are diagnosed early have a longer window. And that's why in sick kids, we are now doing a concept of cancer interception program for these tumors. This all started because we have a drug from the adult world, which is an IDH inhibitor, which has showed that it really works in adults. And we are now trying to use this drug early in children to see if we can actually modulate the biology and intercept the glioma early before it has become malignant. So this is a new concept that we are now exploring and trying to like get grants and funding for, because we can see that if you diagnose these tumors early and do good interception, and interception can be done by many methods. Here it's surgery. You can see that the patients actually achieve complete remission both on radiology, and we do CSF ctDNA monitoring to make sure that they are in molecular remission. So this is a patient with Leaf Romani, a child who was diagnosed with these two white spots, which grew from the child when she was 8 years of age to around 14 years of age. And we didn't really could do anything other than biopsying and showing that these are two distinct IDH mutant astrocytomas in the backdrop of Leaf Romani syndrome, which were low grade and which we knew would transform in the future, but we didn't have a drug or any ability to intercept at that point of time. That changed last year when we were able to do laser, which is like using a very focused high dose laser for treating this small lesion. And as you can see, this is now in remission. And for this longish lesion, we couldn't do laser because it has its size limitations, but we treated with targeted therapy, and the patient after 8 months is showing good response. And in leaf harmony, we already know that IDH mutant gliomas transform and become malignant very fast. So it's not like decades like in adults, but rather 5 to 10 years. But we already see that in a child like this, the use of inhibitor and early surgical interception has made a difference in the MRI and, of course, the clinical situation of the patient. The other concepts that we are using for cancer interception for high-grade gliomas comes from the mismatch repair story, because that can also lead or give rise to IDH mutant gliomas that don't respond well to anti-PD-1 immunotherapy alone. The reason is that IDH leads to an oncometabolite called 2-hydroxyglutarate that immune suppresses the microenvironment. So this is an MRI of a child with IDH mutant astrocytoma on the backdrop of CMMRD who progressed through anti-PD-1, anti-CTLA-4, 2 rounds of radiation. And then when we added the IDH inhibitor, the child responded. We think this is because the IDH inhibitor allows us to stop the production or decrease the level of the 2-HG or 2-hydroxyglutarate, which is the cause of the immunosuppression. And then the immunotherapy can actually do its job, which is killing the tumor cells. So combinatorial therapies, which are biologically rational, based on the biological understanding of the disease process, are making a big headway and allowing us to treat our patients better. So I'm coming to the last part of the talk, and we always get asked that, okay, all of these fascinating discoveries and anecdotes, is it something which is practically applicable to our patients back home? So we were asked to write this review last year, or like last to last year now, that whether all these genomic discoveries are hope or hype. And I leave it to you as the audience to judge this. But of course, as you heard, I am probably biased. So in the Western world, we have clinical trials like this. This is a target consortium led by a consortium called Connect, which is a network of institutions in Europe and North America who do clinical trials together. And this is pediatric high-grade glioma. And this is upfront, mind you, not at recurrence, because at recurrence, basically everyone recurs and everyone dies. So the paradigm is to bring the targeted therapies and the innovative therapies to the front line and not wait for relapse or progression when the tumor biology has already become more aggressive. So treating early based on specific molecular alteration by combination of newer and older drugs. So you can see temozolomide here combined with ribociclib, tovorafenib, which is a new MEK inhibitor, nivolumab and relatlimab for the replication repair deficient tumors, and for the infant type alterations using targeted therapy with or without chemotherapy and radiation is the approach that the global field is now taking. But is this relevant for our patients in India? So I would say that not entirely so, but the simple concepts and the practical differences that are very obvious in some subsets can be applied today in India and probably anywhere in the world. So in the review article, we tried to make things very simple to say that if you have an infant or a young child with one of these infant type alterations, you should definitely avoid radiation because these are young children who don't need radiation. And even with chemotherapy in a previous era, these patients had a longer survival. But now you have drugs, and maybe your adult oncologists are already using many of these drugs. So it's a sort of effort to make sure that we test and sort of get the drug somehow and treat these patients. For older children, at least if you have a DMG or a DIPG, you don't probably need to give temozolomide because it really doesn't work. But maybe you can consider a second radiation or sometimes even a third radiation after consulting with experts, because that not only prolongs survival, it also improves the quality of life. For some, the treatment remains the same radiation with CCNU and temozolomide. But you heard about mismatch repair tumors and V600E mutant tumors where targeted therapy and immunotherapy are really changing the paradigm. And for IDH mutant gliomas, which are rare in children, but maybe some of you will diagnose some of these patients both because of cancer predisposition, or maybe some of you are also treating young adults in addition to children. There, as we talked, inhibitors are really in. They were not in when we published this in 2023, so this was still radiation and temozolomide. But that paradigm is changing now with the availability of IDH inhibitors. So the world is heading towards a place where we can still test, because unless we test, we can't diagnose that. And then we use targeted therapies or avoid treatments that are not effective at least, and try to bring treatments like radiation, which have a proven effectiveness in these patient subsets. Again, some concepts remain the same, not relevant for DIPG, but if you have a hemispheric high-grade glioma, resection is important. Sometimes we are nihilistic and do biopsies, small biopsies, which really don't really have an impact on the outcome. But you can see that if you have a good resection, if possible safely, that can have an impact. And in the adult neurosurgery world, people are now moving towards supramaximal resection because the techniques have become more refined. And even for immunotherapy, we know conceptually that immune-based strategies are probably more effective when the tumor burden is low. So this is a field again that we need to think about differently. DIPGs are a different story, but maybe if it's a hemispheric glioma, even if it's high grade, we have to become a little more aggressive with our surgical colleagues to make sure that a maximal part of the tumor is out and it's not like a big residual that probably is going to be fatal anyway. So I will end with probably two or three sort of summary slides to say that molecular testing, in our viewpoint, is probably imperative for the accurate diagnosis, as you saw, prognosis, and more with treatment. Targeted and immunotherapies are already frontline in some of the high-grade gliomas and having a real impact. Not for all. I don't want to see the world with rosy glasses and see that we have like magic for everything, as you saw. But I do think that we can work with our colleagues in pathology, radiation oncology, and neurosurgery to see how we can adapt some of these algorithms of diagnosis and treatment fine-tuned to the Indian setting where we have to work with limited resources. And one thing that I found very useful when I was working in India is that there are experts for each of these diseases, and it's always like good to reach out to them to learn what is possible and then think about how of many of those you can do for your own patient. So as I was talking, we even like 7 years back now, we treated patients in Tata Medical Center in Kolkata with targeted therapy, with immunotherapy, and tried to do things better because we were in communication with the experts like Eric Buffet and Uri Tabori, who guided us to how to manage our patients. And of course, the big effort that we need to do together is to make sure that we have equity and access to all these diagnostic tests as well as treatments for our patients. And it's not easy. And we all have to work together towards that. So the world is moving towards precision child health globally for all of pediatrics and more so in pediatric oncology and neuro-oncology. And it will take steps for that to be globally disseminated and make things happen uniformly with equity and access across the globe. But we in Sectis are very committed to make this happen and happy to partner with anyone or anyone who is interested to take this field forward. So I will end here by thanking our patients, and these are high-grade glioma mismatch repair patients who are between mixed pictures doing well with the immunotherapy treatment. Colleagues, we work across the globe, the lab and our clinical colleagues and all the funding agencies that fund many of these works. My email is here, so I'm happy to take questions now and also be involved if you have questions over email for specific patients. So I will stop here and see if there are any questions. Thank you so much.
Thank you so much, Dr. Anirban. First of all, congratulations for picking such a difficult topic. Only you could actually simplify this into so many slides and get the crux out of it. So I would actually really congratulate you, because when I discussed the topic with you, the way promptly you picked high grade glioma, that was like, I was like, okay, only you can explain this to us. So first of all, congratulations. And I always say that high grade gliomas is, it always feels like that we get very sad when the diagnosis of a high grade glioma is there on the biopsy report. We always feel that, okay, this is it. We don't have many options for the kid now. We don't have many options for the family now, and we have to spend next 1 hour explaining to them that either it is 2 months or 7 months, and it is the only thing I can write down is either temozolomide or radiation. So it always gets stuck in our mind, and I really hope with changing drugs this 5 year down the lane we do a webinar and say that we have better drugs. We really hope that. So, again, congratulations for treating that spinal high-grade glioma case. I realized, because spinal high-grade gliomas are so rare in pediatric. I hardly remember seeing one or two, but that case definitely is learning lesson. So, shall I take the questions now, Dr. Animan? Yeah,
Sure.
yeah. So, first of all, do you recommend anti-epileptics in high-grade glioma? And there are certain studies which discontinue anti-epileptics in non-cerebral high-grade gliomas. What is your take on that?
So it's a great question, and it's a question which is being asked and answered in different ways as the field evolves. So first, very simplistically, if there is seizure due to a hemispheric hydroglioma, they will be on anti-seizure prophylaxis for a long, long time. So that's something which happens routinely. For the non-hemispheric, there may not be an indication to start, as was already stated. The big question is that how long to continue, given that we don't want to add additional burden. So that's something that we, because of the particular disease type, we don't have an opportunity often to think for a long time. But I do want to emphasize that more and more there is data coming from Michelle Monge's group in Stanford and others who are looking at it from a neuroscience point of view. So today we talked about tumor and the immune system, but there is all this glia and the networks of neural networks that are there in the brain, which have a big impact, we are learning, on how the tumor develops and progresses. So there is some data that some of these antiepileptics, based on either inhibition of GABA or by different other mechanisms, may actually be beneficial in tumor control. So I'm not touting or saying that we should continue patients on antiepileptics or start them on antiepileptics, but this is a big field of research where neuroscience interlinks with neuro-oncology, and it's ongoing research to say that some of these antiepileptics may even be beneficial for tumor control and that is being studied actively right now. So again, coming back to a patient who is in front of me today, I would probably do what is done routinely. So if there was seizure, continue antiepileptics for so many X number of months or years, and because it's high-grade glioma for this patient, the probability of something like stopping usually doesn't arise, unfortunately, unless we have those miracles that we talked about. But the principles follow. We do the same as we would do for another situation. But I think it's important to realize that there is a big neuroscience field evolving that is exploring many of these antiepileptic agents as anti-glioma treatment.
So it's actually like hitting sodium valproate in metronomic chemotherapies of brain tumors.
So it's a bit different because metronomic, as you know, is like more of anti-angiogenic, and valproate has been tried not only because of as a part of the metronomic sort of package, but because of its demethylating agents, because many of those are histone. But neuroscience and neuro-oncology, that story is a totally different story. And there is a lot of sort of data to suggest that the excitatory mechanisms, the GABA and the inhibition of GABA may have effects on how tumor develops and grows. That's why those drugs are being repurposed in trials, but that is in clinical trials. So it's not like standard of care right now.
All right. Do you recommend bevacizumab in high-grade gliomas treatment?
So again, a great question. So there was huge excitement about bevacizumab when it was first tried in high-grade gliomas because everyone saw the contrast disappearing, and we're happy to say that that was response. But now the data is quite clear that it doesn't do anything with improving of overall survival in most types of pediatric and adult high-grade glioma. So it's not. The trials have been done in pediatrics. It was the Herbie trial that showed that there is no benefit with OS. So it's not like a routine practice right now. But again, things change and we learn new things. So currently in sick kids, we use bevacizumab for two indications where we have used radiation for a second or third time. As you saw, we have sometimes in DIPG. So their radiation necrosis is sometimes a problem and sometimes a risk. So we have used bevacizumab to allow a second or a third dose of radiation and or treated radiation necrosis due to bevacizumab. The other indication which we are learning more and more is when we treat these hypermutant gliomas with immunotherapy, sometimes they can have immune reaction which leads to a lot of edema. And because the CNS is a closed compartment, it leads to increased pressures. And steroids are a knee-jerk reaction, very easy to give, but steroids then blunt your T cell response. So there we use bevacizumab with immunotherapy to modulate the vasculature so that the edema part gets controlled. And there is some data emerging that in that context of immunotherapy, there may be some synergism of immunotherapy and anti-VEGF. But again, that's research. Clinical trials are happening both in adults and children. So summary is that don't use it routinely unless you have a specific clinical indication or a specific research question.
True, I totally agree with you regarding the Bevaccy thing. Do you recommend a diagnostic CSF in all cases of high-grade glioma in pediatric age group?
So again, great question. And of course, I am giving ambiguous answers because the world is actually ambiguous in this disease. So again, for routine purpose, no need, I would say, because if it's a high-grade glioma, it's usually that the local disease will kill your patient, unfortunately, before it disseminates. But again, we learn new things. So in sick kids, nobody did CSF 4 years back, maybe. But now we are using CSF ctDNA as a surrogate, again in a research question level, to see if that helps us understand how the tumor evolves and how we can get ahead of a true progression by diagnosis early. So we use CSF basically again after a long time in these patients for 3 or 4 indications. One is that when the patient refuses for a midline glioma biopsy, because otherwise it's almost a standard now in the West, we want to still use or find the K27 because some of these, as you know, can be low grade tumors without K27 and have a totally different outcome. So we offer CSF as a surrogate for biopsy because we can do ddPCR and detect the K27 mutation from those patients. So that is one indication. The second indication would be that now that we treat patients with radiation second, third time, which is all local usually, we are seeing that at the end, even DMGs, which are supposedly local disease killing local due to local effects only, they actually all disseminate in the end. And at autopsy, we find that they have all disseminated disease in the brain and the spine. And some of those spinal diseases can also cause like cord compression, which needs like focal radiation for that area. So we again are using CSF as a research tool, but not for clinical use. And for the mismatch repair tumors on immunotherapy, it's again a surrogate to see or monitor treatment response to distinguish between immune-based pseudoprogression versus true progression, and also tracking the mutations as well as the copy number changes in the CSF. So it's a good research tool which is emerging in a big way, both for diagnosis and following up of treatment, but not outside of a research context in a routine clinical sense in a day-to-day practice.
Do you have any experience in a short delay to start radiation post-surgery for a high-grade glioma?
So again, it's a fact that most of these are fatal diseases. So radiation will buy you time and allow you to try other stuff if there is an opportunity to do that. So I would say that we should still follow the paradigms of starting radiation on time, especially if we have had good surgery, not for DIPG, but for the hemispherics. Because if you delay, like if you have a good resection of a G34, let's talk about hemispheric G34, where the survival is like 2.5 years if you have GTR. But if you do not consolidate that GTR with the immediate radiation, if you have a 3 months delay, the tumor will grow back and then you lose that advantage. So I would recommend that. I know we work in different settings and we have referrals and delayed in referrals. So the intent should always be to follow and do things on time. But again, I'm being pragmatic in saying that we can be like, we don't need to be as aggressive as in a medulloblastoma to say because we have cure and delaying radiation may hamper cure. Here, we still need to do it properly. And I would want to reinforce that the molecular part is very important because unless you have an accurate diagnosis, you will probably not be able to do the proper treatment for your patients, be it radiation or something else.
Next question is definitely a question which always comes to any neuro-oncology discussion we do. Radiation recommendation, doctor, proton versus photon.
So again, an important question. And for high-grade glioma, that question is again probably less relevant in a way, as we all know. So it's a research question, and as you know, it's not a question of efficacy. And in Canada and in sick kids, we still treat high-grade gliomas with photons and not with protons. So I think for high-grade gliomas, that debate is still not there yet. But again, with all of those targeted therapies and immunotherapies, if somebody does become a long-term survivor, then that question may change. But for today, because how expensive proton is, for a high-grade glioma in India right now, I would probably stick to photon and not to proton.
Temozolomide in mismatch repair is avoided. Any specific reasons for that? I think you already
Yes.
explained that very well,
So
but
temozolomide needs an intact mismatch repair system. So if it's not there, it's deficient by default in that tumor, then temozolomide is like water.
so practically we're left with only lomustine in such cases, actually.
Lomustine, I would say, why not anti-PD-1? Because the adult oncologists are using it all the time. And we have a clinical trial that uses it upfront right now with good benefit. So I think we have access. So we should try to get that access. And sometimes working with the companies, they often allow us to, because I did it for my patient back home. That's why I know it can be done if we really push for it.
So do you mind me asking which dosing protocol actually are you using for NTPD1?
So for the mismatch repair tumors, we are right now using Nivo and Pembro the same. So we use Nivo more because we have more relationship with the company in giving access in many parts of the world. So we use 6 mg per kg every 4 weeks. So there is good data from adults that the 2 weekly and the 4 weekly regimen are equi-efficacious, and the same for Pembro, 3 weekly and 6 weekly are equi-efficacious. And because we work so much with LMICs, coming every 4 weeks is easier for patients in every way. So we usually use Nivo every 4 weeks and Pembro every 6 weeks instead of doing the shorter regimen, which was initially tried.
And you continue that post radiation also?
Exactly. So it's used as maintenance therapy for that particular subset of tumors for 2 years at least, if not like longer or like there are caveats to that. And it's a big discussion in itself, but at least for 2 years, there's good response and good biology.
And you're getting good responses with it.
Yes, as you saw, that survival was zero, it's 40%, and now we have three subgroups. Some have 80%, some have 20%. and we have different strategies. So it's not like you get a mismatched repair tumor and you blindly start anti-PD-1. You should probably find out which subgroup it is, and then you can direct your patient. In India, I'm saying, if you have an 80% outcome, you would push for everything and try to get funds and everything. Whereas if your outcome is like the bad subgroup within that subgroup, then you may want to choose palliation alone. So that's why I think that subgrouping is very important for treating patients, not for like esoteric fancy reasons.
So frankly speaking, we've been reading about it a lot, but practically we have not done it at our center. But definitely with caveats explained, it is an area to explore. Um, do you promote liquid biopsy in all cases of your hybrid glioma nowadays? I think you also
So
do
it's a
that.
research question. We have open research protocols both in sick kids and through the Pediatric Brain Tumor Consortium, which is all of North America, where we do that. It's being standardized and we are finding it to be very useful in the settings that I talked about, but it's still in the research domain, not something that we should do blindly for every patient with high-grade glioma. In medulloblastoma, that is different. It's really changing how we manage with liquid biopsy and monitor with liquid biopsy.
Just the last question for the evening. Does radiation also means a re-challenge with temozolomide?
So usually we don't re-challenge with temozolomide during radiation, because radiation we often or most commonly do for the DMGs. And as I said, in DMGs, I know there are like people who still favor temozolomide, especially from the adult side, but in pediatric neuro-oncology, most physicians will probably not do temozolomide anyway. So it's radiation, second radiation, maybe a third radiation without temozolomide. And the other setting that we use radiation is often for the mismatched repair tumors where temozolomide doesn't really work. So usually it turns out to be radiation alone and not with anything, like not with temozolomide usually.
All right. That's it with all the question bugging, Dr. Anirban, and I take a wrap for the evening. Thank you so much for this enlightening lecture once again. Thank you so much for hitting this important topic. And to all the listeners and the colleagues, seniors and juniors, thank you so much for the patience and amazing discussion. And we have Dr. Anirban's mail. We have my mail ID. Any questions, any discussions, we are open to. Thank you so much.
Have a good rest of the evening. Bye.
Yeah, good evening, everyone. Have a good day, sir.
Thank you, Dr. Swati. All right, Yogesh, we can end the meeting.